Hello, good evening.
Good evening,
So
sir.
I can see Sujoy has joined, and Aparna will be joining a little late, and then hopefully uh, he will also join. Kumar Prabhat. So I will start at 7 o'clock. Can you all hear me?
Yes, sir.
Yes, sir.
Oh, so welcome back for our seminar series on somatic NGS and overview of precision oncology. Today we are covering three diverse sites: esophagus, stomach, liver, pancreas, and biliary tract cancers. And Anchal Pandey, who's our genetic counselor, will present the seminar. And the moderators with me are two medical oncologists, Dr. Sujay Srinivas and Dr. Prabhat Bhargav. Sujay was with us at TMH. Now he's practicing in Kerala. And Dr. Prabhat Bhargav is a consultant medical oncologist with us at TMH. And along with me, Dr. Aparna Dhar will be there. So you can start your presentation now.
Thank you, sir, for introducing me. First, I'd like to thank all the moderators to accept my invitation and go through this presentation thoroughly. So in this session, I'll be talking about very diverse cancers with distinct biology and driver mutations, starting with esophagus, stomach, liver, gallbladder, and pancreas. As you've seen little ribbons that I have attached, so esophageal and stomach cancers can be indicated by periwinkle ribbon. Liver cancer can be indicated by dark green or emerald green. Gallbladder and bile duct cancers are indicated by light green color, and pancreatic cancer by purple color. So talking about absolute number of incidences and mortality in case of whole world versus India, if you can see, I have highlighted few cancers. Liver cancer, where it's third most common in the world, it ranks ninth most common in India. Stomach cancer, which ranks fifth, ranks sixth in India. Pancreatic cancer, which is sixth in the overall world, ranks 18th in India. Esophageal cancers, they rank at seventh most common at the world. However, they are fifth most common in India. And if you see gallbladder, which is at the top, which is at the bottom, we can see 20th most common in the world. However, when compared to Indian population, it is 14th most common. So we have around 210,000 plus cases in upper GI and hepatobiliary cancers with higher mortality rates as they tend to present in later or advanced stages. Except for gallbladder, if you can see in this table, most cancers are more common in men. In case of gallbladder cancer, it is more common in female as well as in the gangetic belt in North India. Stomach cancers are most common in South and Northeast Asia, India, sorry, and esophageal cancers are more common in Northeast India. Talking about our first organ, esophagus, esophageal cancers can be divided into three subtypes based on their histology. First is adenocarcinoma, next is squamous cell carcinoma, and then there's small cell carcinoma, which is of neuroendocrine origin. So talking about adenocarcinoma, it occurs in the lower third half of esophagus and GE junction. Squamous cell carcinoma occurs mostly in upper and middle third of esophagus, and small cell carcinoma is rare throughout. Main factors for adenocarcinoma is GERD, which is gastroesophageal reflux disease, Barrett's esophagus, obesity, poor diet. In case of squamous cell carcinoma, tobacco, alcohol, poor nutrition, and diet are the major factors. Talking about geographical patterns, adenocarcinomas are more frequently seen in Western population as compared to Asian and African, where squamous cell carcinoma is more prevalent. Talking about key molecular features, so HER2 amplification and MSI is more commonly seen in adenocarcinomas, whereas squamous cell carcinomas tend to present with TP53 mutations and CDKN2A alterations. Overall prognosis, if we talk about both these cancers, adenocarcinoma and squamous cell carcinoma, are moderate prognosis. They are very much dependent on the stage. However, small cell carcinoma is very poor and has very aggressive behavior. However, due to the time constraints, I'll be covering the two most common, which is adenocarcinoma and squamous cell carcinoma cancers. Talking about staging, the very basic diagram, as you can see, T0 can be classified where there is a tumor invasion in submucosa. T2 can be where invasion is in muscularis propria. T3 is where invasion is in adventitia. And then T4 is where the adjacent structures are involved. Node status can be found if there are no regional lymph node with metastasis, then we state it as N0, and then N1, N2, N3 based on number of lymph nodes found positive for metastasis. M0 is no distant metastasis, and M1 is distant metastasis to different organs. This is a ESMO guideline practice. Back in 2022, they had published a very clear diagram which states in case of early diseases, if they are caught, which is very uncommon, so resection can be one way to go. When talking about SCCs, neoadjuvant CTRT or definitive CTRT can be given. In case of adjuvant, neoadjuvant FLOT or neoadjuvant CTRT can be considered. Talking about genetic landscape of esophageal cancers, so as I explained earlier, TP53, CDKN2A is more common in squamous. Adenocarcinoma has TP53, ARID1, and SMARC4 more commonly found. So while talking about amplifications or any kind of CMVs, PIK3CA, TP63 is common in squamous. In case of adenocarcinoma, it's MET, ERBB2, EGFR, MYC, KRAS, and CCNE1. So for as of now till date, we do not have any particular pathway that we can specifically target for squamous cell carcinoma. However, in the case of adenocarcinoma, HER2 pathway can be targeted and VEGF pathways can be targeted. Tumor agnostic pathways, which involves NTRK and BRAF, RED, can also be targeted since they are tumor agnostic, meaning that irrespective of the site, they can be given in the situations. So talking about HER2 pathway a bit in detail, HER2 is a transmembrane receptor from ERBB family of receptor tyrosine kinase. Overexpression of HER2 leads to tumorigenesis. So to target HER2, we have anti-HER2 monoclonal antibodies, which is trastuzumab, as proven by TOGA study, and trastuzumab deruxtecan, which is proven by Destiny trials. Both of these drugs are approved if HER2 is found positive in IHC, and they are approved only in advanced and metastatic stages. Talking about VEGF pathways, this pathway is present to promote the migration and proliferation through angiogenesis, and it is significantly correlated with the progression and prognosis of esophageal cancers. So drugs such as ramucirumab have been proven from Rainbow trial and Regard trial for the usage, and the use is mostly restricted towards metastatic and lower esophageal cancers. Talking about our next organ, which is stomach. So stomach can be divided into stomach cancers can be divided into four subtypes: adenocarcinoma, lymphoma, carcinoid tumors, and gastrointestinal tumors. So the highest range incidence in India was recorded from the district of Aizawl from Mizoram state, accounting for around 62 cases out of 1 lakh cases. So, gastric adenocarcinomas can be briefly divided into 4 subtypes according to the Cancer Genome Atlas. First is Epstein-Barr virus, which is characterized by viral infection leading to hypermethylation of the genes involved. Microsatellite unstable tumor where DNA mismatch repair pathway falls defective. Genomically stable tumor, which is third, where there's a lack of widespread mutations. However, it is more commonly found that CDH1 is mutated in such situations. And then fourth is chromosomal instability, where there is a lot of chromosomal aberrations that happen, or a lot of CNVs, copy number variants that happen. And these are more tend to be take benefits from adjuvant chemotherapy. Around 5 to 10% of familial gastric adenocarcinomas have been noticed, out of which 3 to 5% are a part of inherited cancers. Here I have listed few cancers which are part of syndromes in case of gastric adenocarcinoma, and these are different genes. We'll talk much in detail about them later. Coming to staging of stomach cancer, T1 invades the lamina propria, T2 invades the muscular propria, T3 invades the adventitia, and fourth invades the neighboring structure. If there is no metastasis to the regional lymph node, it is termed as N0, and N1 and N1 to N3 can be classified based on number of lymph nodes found positive for metastasis. So, coming on to the management of gastric cancers, I have divided it into 3 different types. Early gastric cancer, again, very rare to see. Endoscopic resection and surgery is the way to go. If H. pylori infections are seen, then the eradication can be done and adjuvant chemotherapy can be given. In case of locoregional disease, where it's T2 to T4 nodes are positive, but it's not metastasized to different distant organs, in that situation, perioperative chemotherapy alongside of radical gastrectomy, according to flawed protocol, can be given, followed by adjuvant chemotherapy. For case of advanced disease, palliative chemotherapy or radiotherapy can be chosen. Palliative surgery can also be chosen in very specific selected cases, or in cases where the disease has been spread a lot, supportive care can be given. Talking about an Indian multi-centric trial data that 2 of our moderators have been part of. So they have found that when they were trying to understand the Folfox or Capox alongside of docetaxel, is it causing any effect or not? So they also did genomic profiling of few cases, and they found that somatic BRCA alterations have increased around 16%. So, in this stomach adenocarcinomas, it's more commonly to target EGFR or HER2 pathway and Claudin 18 path. So these are few targeted therapies for gastric adenocarcinoma. Talking about anti-HER2, more amplification is seen towards it, and there are few oncogenic point mutations that happen. Trastuzumab and trastuzumab deruxtecan can be given. They have been approved for later lines. FGFR agents, so FGFR is found in around 9% amplified and 3% in fusion. So bemarituzumab is a drug which can be used to target FGFR. However, it's still in phase 3 studies and it is yet to show any kind of results. VEGF agents can be used, such as ramucirumab, which is approved for second line of therapy from REGARD and RAINBOW trial. NTRK agents, where we are finding a lot of NTRK fusions, larotrectinib and entrectinib can be given as under the tumor agnostic blanket approval. And Claudin 18 agents, when Claudin CLND 18.2 is positive in IHC, then zolbectuzumab can be given, has been found to increase the progression-free survival as well as overall survival through Spotlight and GLOW trials. Immunotherapies, first line standard of care is to combine PDL1 for advanced and metastatic gastric cancers. There are two trials, Checkmate 649 trial and Keynote 859 trial, which has confirmed somewhere that it improves OS and PFS. However, perioperative use of immunotherapy is still under a lot of study and under phase 1 or phase 2 trials. Talking about another subtype of stomach cancer, which is gastrointestinal stromal tumor, 18 to 25% of GIST cases are incidentally diagnosed, and most commonly found mutations are commonly found mutations are KIT mutation around 70%, PGDFRA mutations around 10%, and wild type around 10%. KIT can occur throughout the lining of throughout the GI lining. Most commonly, it is found in stomach. However, it can occur in small intestine and rectum as well. So there are different ways of identifying KIT and PGDFRA or any other biomarkers. Through IHC, we can confirm that the histopathology immunohistochemistry can confirm the GIST through KIT and DOC1. If it is found positive, then yes, it is leaning towards GIST. Then RT-PCR can be done for very hotspot known mutations such as KIT exon 11 or exon 9 or PGDFRA T842V. Talking about NGS, it is better to do NGS in such situations because it gives an overview of how different biomarkers such as KIT, PGDFRA, SDH, RAS, BRAF, and NF1 are involved. So molecular classification of GIST, it can be divided into two different types. First could be GIST PGDFRA mutant and another could be wild type. So if it is mutant, it is classified as primary familial GIST syndrome. If it is wild type, through IHC SDH, we can find out that it is either deficient or competent. In case of deficient, then we can classify the GIST into Carney's triad or Carney's Straticus syndrome. In case of competent GIST, BRAF and NF1 can be checked. Talking about driver mutations of molecular GIST, KIT mutant GIST occurs in around 67% of the cases, out of which 11 codon is found to be very aggressive and has increased risk of relapse. KIT exon 10 M541L switch, there are 20% of cases and it has increased risk of progression. Both of these, exon 11 and exon 10, have a robust response to first-line imatinib. Repotrectinib can be used to target resisting mutations in KIT in exon 70. PGDFRA mutant GIST occurs in around 16% of the cases, out of which PGDFRA D842V mutation is imatinib resistant. And to target that, we have avapritinib, which has shown promising results. In case of non-D842V mutations, the response is significantly seen in imatinib. Talking about GIST without KIT or PGDFRA mutation, SDH deficient GIST can comprises of 7 to 8% of the cases. It is resistant to imatinib and shows partial sensitivity to VEGFR2 inhibitors, which is sunitinib and regorafenib. It mostly occurs in stomach. In case of NTRK or FGFR2 fusion, they mostly occurs in small intestine and they are resistant to KIT or PGDFRA TKIs and more sensitive towards larotrectinib, enterectinib, and erdafitinib. BRAF mutant GIST, which is rare, again it is resistant to imatinib and sensitive to BRAF inhibitors such as dabrafenib and MEK inhibitors, and again it occurs mostly in small intestine. So these are few tumor syndromes that are associated with GIST. If germline KIT or PGDFRA mutations are found, then we can classify the GIST as familial or hereditary GIST. NF1, if it is found in germline, it can lead to neurofibromatosis type 1. So other manifestations are neuroendocrine tumor, neurofibromas, malignant peripheral nerve sheath tumors, etc. In case of Cartney strategis, that is SDH, A, B, C, D are found to be germline. Then SDH deficient pheochromocytomas or paragangliomas can be other manifestation alongside of GIST. Now coming on to our third organ, liver. Most commonly found is HCC, which is around 90%. Main risk factor is cirrhosis of any etiology, and as you can see in the photo, the epidemiology is around 1 in 189 males and 1 in 514 males. Females, I'm so sorry. Risk factors include chronic HPB or HCV infections. It is present in more than 80% of the cases, and it is specifically found in India. It's more common cause of HCC. Alcoholic liver diseases or metabolic factors such as obesity, diabetes, or non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. These are also causative agents for development of liver cancers. There are other causes such as aflatoxin, autoimmune hepatitis, Wilson's disease, etc., on which in which I won't go much in detail about right now. So to classify HCC, we have Barcelona Clinic liver cancer staging. It is classified into 5 stages. Stage 0, again, it is very rare and resection can be the way to go ahead. In case of A to C, it is subdivided into early stage A, intermediate stage B, and advanced stage C, where we have multiple options such as liver transplantation, TACE, or sorafenib, which can be given in advanced stages. In the stage D, which is a terminal stage, best supportive care can be offered. Key molecular aberration and pathways. So here I have mentioned 4 main aberrations that happen. First is TERT promoter. Around 40 to 60% of the cases we have seen TERT promoter aberrations happening. It is present in early stages of HCC and reflects poor clinical outcome. CTNNP1 mutation occurs in 20 to 40% of the cases and has shown resistance towards immunotherapies. TP53 mutation occurs mostly in advanced stages and is linked towards aflatoxin B1 food contamination and is found aggressive. KEAP1 and NRF2 dysregulation is significant in finding metachronous HCC versus synchronous HCC and has decreased efficacy towards TKI. Other pathways which can be targeted are PIK3-AKT mTOR pathway or RAS-MAP-VEGF pathway. So here I have listed few systematic targeted approaches in HCC. Talking about multi-kinase inhibitors, drugs such as sorafenib or levantinib, regorafenib, cabozantinib are FDA approved. There are specific RTK inhibitors. For an example, ramucirumab for VEGFR2, it can be given. Pathway-specific inhibitors are mostly in under early stages or early trials where we are discovering about MAP kinase inhibitors, PIK3-AKT mTOR inhibitors, WNT-catenin inhibitors, CDK4/6 inhibitors, etc. Immunotherapy in HCC. So we have few FDA-approved combinations such as atezolizumab and bevacizumab, which is breakthrough first-line therapy. Durvalumab and tremelimumab, I'm so sorry for the pronunciation, is FDA approved for advanced HCC. And camarelizumab and apatinib have been found superior to sorafenib. Next organ that we'll be covering is gallbladder. So unlike in West where cholangiocarcinoma is more common, gallbladder cancers are more common in India and has higher prevalence in the Gangetic belt. Around 5 year survival rate has been found for 20% cases. And here I have listed few risk factors. First is age and gender. The risk of the cancer increases with the age and it is more commonly found in females. Gallstone, cholecystitis, porcelain gallbladder, infections, or obesity are also few of the risk factors. Staging of gallbladder. So here I have, as you can see in this photo, T1 stage is the tumor not being limited to the cirrhosis between the mucosa and the lamina propria. T2 is very much confined to the gallbladder. T3 is involvement of hepatic organs nearby, and T4 is where two or more than organs are involved. Similarly, in case of nodes, we can understand if the nodes are positive based on the number, we can classify it as N1, N2, or N3. Metastasis M1 is distant metastasis to different organs. So for early stages, resection is a great way to go ahead. However, in advanced stages, there is always a conflict of NACT or adjuvant chemotherapy. Talking about few biomarkers and their identification in gallbladder cancer, TP53 is found in 73% of the cases. Most of them are substitution and insertion deletions. CDKN2A around 25% of the cases, and PIK3CA in around 20% of the cases. Copy number alteration has been found in CDKN2A deletion around 11%, and ERBB2 amplification, which is HER2 amplification, found in 13.3% of the cases. There is FGFR fusion, which is also commonly found in gallbladder cancer. So through IFC, we can understand P53, CEA, CA19.9, IMP3. So these few are to distinguish gallbladder cancer from benign lesions. HER2 can be covered through IFC. And through NGS, we can understand the whole picture going on in the background. So there are different pathways that we can target in gallbladder cancers. First is ERBB receptor, where we have EGFR and HER2. HER2 can be targeted through trastuzumab, pertuzumab, or lapatinib. And PIK3-AKT mTOR pathway is found in around 16% of gallbladder patients, out of which P10 is more commonly mutated. It has led to poor prognosis. MAP kinase pathway, KRAS has been found in around 13% of gallbladder cases, out of which codon 12 have been found to express decreased overall survival rate. BRAF is found in around 5.9% of the cases, and these are mutations or any kind of oncogenic drivers. Amplification is around 5%. CMET overexpression is around 39.8%. DNA damage repair, DDR, which involves the different repair pathways to repair the damaged DNA. In that, ATM and BRCA2 are most commonly found, and even in ATM, if you can read, there's 50% occurrences, prevalence of ATM more found in gallbladder cancers. So the therapies that we can give in gallbladder cancers to target these pathways. First is EGFR inhibitors. Anti-EGFR monoclonal antibodies such as cetuximab or panitumumab or alongside of chemotherapy can be considered. However, all these listed options are in early phase studies with modest response, so they are currently not approved as of date. HER2 can be blocked through trastuzumab, and TAP study has shown that using trastuzumab has shown benefit in gallbladder cancer treatment. Trastuzumab deruxtecan can be used for patients in later lines where the patient has progressed on prior HER2 treatment. There are other early phase trials in different pathways as well, such as targeting PIK3 AKT mTOR pathway is everolimus, MK2206, and copalnicinib. They are also in early stages, talking about if VEGF and VEGFR, bevacizumab or regorafenib or ramucirumab are also in early phase trials. There are no approved drugs for these for targeting these pathways as of date. Immunotherapy, we have seen around 54% cases have been found positive for PDL1 expression, and all these ICIs, which are nivolumab, pembrolizumab, durvalumab, they are currently in phase 1, phase 2 trials, and we are waiting for results to understand if they can be given or they can be approved or not. Coming to our next organ, which is bile duct. So bile duct is umbrella term for all the biliary tract cancers. Around 3% of gastrointestinal malignancy are from bile duct. And the subtypes, bile duct cancers can be divided into two subtypes. First is intrahepatic cholangiocarcinoma, and second is extrahepatic cholangiocarcinoma, which can be subdivided into perihilar and distal uh, extrahepatic cholangiocarcinoma. So here I have listed few risk factors, which are chronic inflammation, cholangitis, liver fluke infestations, hepatitis, chronic hepatic stones, etc. So these could be leading cause for bile duct cancers as well. So talking about presentation, ideally a lot of patients, they present with advanced or metastatic stages, as the symptoms are very vague and not specific at all. So most of the time it is unresectable or metastatic disease where the overall survival is around 2%, and there's a very good high recurrence rate as well. Cholangiocarcinoma can be subdivided into histologically, as I had informed in previous slide, intrahepatic, perihilar, and distal. Talking about molecular classifications, so if you can see in this picture, ICAA small bd, which means small bile duct. This is more. This has more of IDH1 and 2 and FGFR2 alterations if compared to large bile duct, which is ICA large bile duct here. It has more of KRAS, TP53, SMAD4 alterations. And if we talk about extra hepatic, which is perihilar and distal, then ARID1B, PRKACA, and BRAF are more commonly found in those cancers. This is the overall treatment approach chart that we use. So surgery is done in earlier stages. In later stages, chemotherapy, radiation therapy, or targeted therapies are considered. So this is a very good picture to analyze the timeline of all these coming precision medicines or immunotherapy that we have been using nowadays. So for FGFR, IDH, BRAF, NTRK, KRAS, these are used as later second or third line of therapy. So let's talk more in detail about that. Talking about FGFR2 fusions, it is more prominently found in ICAA. And permigatinib and futibatinib is FDA approved. IDH1 and 2 mutations can be targeted by ivosidenib, which are more commonly found in small duct ICCA. BRAF mutations are again found in ICCA in around 3 to 6% of the cases. Dabrafenib, which is a BRAF inhibitor, and trametinib, which is MEK inhibitor, combination has been found successful in such situations. HER2 amplification is more commonly seen in extrahepatic region, where there's around 15% of the cases have been found amplified. Pertuzumab and trastuzumab has been found to be effective through my pathway trial. And trastuzumab deruxtecan can be used for later lines. NTRK fusions is present in around 4% of bile duct cancers. And to target them, we have larotrectinib and entrectinib, which are FDA approved. KRAS mutation, so it is more commonly found in large duct ICCA, and adagrasib is one option to target KRAS G12C mutation. Immunotherapy, if we talk about, less than 2% are MSI high. So one of the study, Keynote 158, phase 2 study has showed that pembrolizumab in advanced BTC has been found with a good rate. This picture, it gives a complete analysis of common genomic alteration and differentiation of different location based in the biliary tract cancers. Now, coming last but not the least, pancreas. It is 7th leading cause of global cancer mortality, and 5-year overall survival is around 6 to 10%. If we see, it is again presented in later stages, as early stage diagnosis is very rare. Risk factors are increase in the age. After the age of 50, the risk increases around 20%. Males are more susceptible as compared to females. Smoking also increases the risk, as well as few medical conditions such as pancreatitis or diabetes mellitus, and even genetic or hereditary factors. So when we talk about pancreatic cancer subtypes, most commonly found is ductal adenocarcinoma in around 85% of the cases. Other histologies are also found in 1 or 2% of the cases. Here we'll restrict our talk to PDAC, which is ductal adenocarcinoma. Talking about the staging, as we can see, if T1 is very much restricted or localized, T2 is slightly spread tumor, and T3 is spread to nearby organs. Nodes can be positive, and status can be determined through nodes, how many nodes of them are positive. Talking about therapeutic options, it is again, as I mentioned, uncommon for localized pancreatic disease to happen. So ideally, it is more on the unresectable or metastatic pancreatic cancer cases that we observe. And in such situation, surgical options can be considered. However, chemotherapy and radiation therapy is ideally the way to go ahead. So let us understand the initiation and progression of pancreatic cancer. So a normal pancreatic epithelium, it undergoes a driver mutation of KRAS and forms something called as pancreatic intraepithelial neoplasia 1, which is PANN1. KRAS is the first mutation to happen, followed by CDKN2A and TP53 and SMAD4, which ultimately leads to pancreatic ductal adenocarcinoma. So, as I mentioned right now, that KRAS occurs in most of the PDAC, around 90% of the cases. Most common mutation is codon 12. So, we should also assess which exact variant are we talking about in codon 12. So, G12D is around 40% common, G12V is 34% common, and G12C is only 1%, which all of this indicates aggressive nature and poor prognosis. So we have sotorasib or adagrasib to target KRAS G12C mutations, but however, since it's rare, we do not tend to use it much. However, targeting KRAS G12D inhibitors can be used. Sotorasib is under investigation. TP53 is again a driver mutation that happens. It is present in high-grade panel lesions and occurs in around 50 to 70% of the tumors. Several MDM2 inhibitors are seen under clinical trials, but as of now, we do not have anything to target it. CDKN2A is a tumor suppressor gene, and its inactivation is detected in around 60% of PDAC cases. Palbociclib and ribociclib are few drugs which we can use. However, they are in phase 1 and phase 2 study. SMAD4 is a tumor suppressor gene which is inactivated in around 50% of PDAC cases, and it also indicates higher metastasis rate. However, it is undruggable as of now. There's another targeting pathway, which is DNA damage repair, which we can easily target. We have POLO trial to back the data that PARP inhibitor olaparib has been found to give beneficial response in BRCA mutated pancreatic cancer after platinum-based therapy has been given. So this picture shows the overview of precision medicine in pancreatic cancer. Around 5 to 7% of BRCA cases have been observed, in which olaparib can be considered. MSI high is just in 1 or 2% of the cases, and pembrolizumab can be considered in such situations. NTRK fusions are very rare; it's present less than 1%, and larotrectinib and endarterectinib can be considered. So these are few inherited disorders with increased risk of PDAC. BRCA2, which is from hereditary breast and ovarian cancer syndrome, STK11, which is Peutz-Jeghers syndrome, Lynch syndrome, or familial pancreatic cancer, which is PALB2, can also be inherited. So let us talk about key hereditary cancer syndromes associated with today's organs. So first is hereditary breast and ovarian cancer syndrome. It occurs very vastly, and around 5 to 10% risk is of pancreatic and esophageal cancers. Pancreatic screening can be started from the age of 50 or less than 10 years from the earliest diagnosed pancreatic cancer incidence in the family. For that, annual MRI or MRCP can be done. Uh, Let us talk about hereditary diffuse gastric cancer, which is caused by CDH1 and CTNNA1. It is around 3% of the global burden of gastric cancers, and it is characterized by signet ring cell cancers or diffuse gastric cancers, as well as lobular breast cancers. So, the surveillance for it with respect to upper GI and HPB will be prophylactic gastrectomy. However, it initiates the issue between risk reduction surgery, which we are doing, which reduces the risk of up till 1%. However, the quality of life is impacted, and there could be post-surgical complications that can happen as well. So another option could be through annual monitoring and surveillance through annual upper endoscopy. Peutz-Jeghers syndrome, around 90% of the patient develop hematomatous polyps in small bowel. However, Peutz-Jeghers is also known to affect stomach and gallbladder. Around 29% of risk is present in stomach for stomach cancers, and the gene associated is STK11. Annual surveillance would be esophageoduodenoscopy, which is EGD, alongside of colonoscopy and MRCP or EUS. Talking about juvenile polyposis syndrome, it is development of juvenile polyps in the digestive tract. Mostly the risk is in colon. However, stomach has a risk of around 21%. Genes which are associated are SMAD4 and BMPR1. Surveillance can be done through upper endoscopy and high quality colonoscopy. Talking about familial adenomatous polyposis (FAP), there are two variants of it. First is classical FAP, where we have found more than 100 polyps, and then there is attenuated FAP, where there are 10 to 100 polyps. So there is a 15% risk of stomach, duodenal, and pancreatic hepatobiliary cancers. And to check on that, we can do annual surveillance of colonoscopy and endoscopy, as well as prophylactic total protocolectomy can also be considered, or any other appropriate surgery can also be considered. Let us move to mute by edge associated polyposis, which is MAP. We should always remember that this particular syndrome is autosomal recessive. That means it needs two copies of mute by edge to be mutated to be actually reflected into creations of polyps. So there are around 10 to 30% of cases where gastric polyps are found, and surveillance can be done through high quality colonoscopy. Next is Lynch syndrome. So the genes associated are MLH1, MSH2, MSH6, PMS2, and there are different risks for different genders. In case of MLH1, there's a risk of 22% of developing cancers in upper GI and hepatobiliary regions. In case of males, it's 11%. For MSH2, it's 13% for females and 20% for males. In case of MSH6, it's 4% in females and 8% in males. So PMS2, it is 4% for both sexes. So annual surveillance can be done through colonoscopy, EGD with extended duodenoscopy, serum CEA and CBC, and annual fecal ocal blood. Talking about another syndrome, which is gastric adenocarcinoma and proximal polyposis, which is GAP syndrome. It is very rare for it to happen, and polyposis is very much restricted to stomach. So the gene associated with it is also APC. However, the main difference between FAP and GAP syndrome is that in GAP syndrome, APC promoter 1B region is affected. So in this case, in this syndrome, since we do not have very good amount of data, as of now, gastric endoscopy surveillance is recommended. So let us talk about few cases. First case that we have observed in our cohort is a case of 55-year-old male diagnosed with metastatic unresectable intrahepatic cholangiocarcinoma, and BRCA1 was found at a VAF of 47% in NGS panel for solid tumors. So in this situation, although he had received 8 cycles of GemCis, there was a partial response when assessment was done through PET-CT, and followed by he received gemcitabine and low-dose nivolumab for 3 months and gemcitabine and low-dose nivolumab monthly. The somatic variant, which was found at 47.9% VAF, was also identified in germline Sanger sequencing. However, we do not have any randomized trial currently specifically evaluating the PARP inhibitors in cholangiocarcinoma with BRCA mutations. So I would like to hand over the discussion to Dr. Sareen and all the moderators if they have any case to discuss.
Okay, thank you, Anchal. You made a good presentation. And
Thank
we
you, sir.
have with us the faculty, Dr. Sujay Srinivas and Dr. Prabhat Bhargav. Both of them are consultant medical oncologists. And Dr. Aparna Dhar, who's a genetics expert and a lot of experience in precision medicine. So, Anchal, I just want you to put that slide where you looked at esophagus, you compared different region risk factors, then we will initiate the discussion, just to drive home a point. If you can again start sharing your screen, where you showed the squamous carcinoma or adenocarcinoma, and then you
Yes, sir.
also had a study from Tata Hospital, both of them are here. So I want to just start the discussion with that.
So
So
do you want to
Anchal
talk
was
about this
complaining, so you
particular
gave me
one?
a topic which has too many cancers. Go back to that. Go back where you described. Yeah, okay. No, not stomach. Huh? Sorry, esophagus. You start with esophagus.
This
And then
one, sir?
before this.
You were on the right side where there is a data of TMH genetic analysis of
Yes.
mutation analysis.
Yeah, here.
Yeah. Okay.
Yeah.
Let's discuss this. So, why the TCGA you have shown that, but the study, the results that they have, why do you think they are different? I'm asking you, Anchal. Of
Sorry.
course, the experts will explain.
So what was the question? Sorry.
Can you hear?
Yes, yes.
So, when was TCGA data published? Their classification.
Sir, it was ideally initially published in 2014.
Okay,
However,
so
since
I think that's the point, that in 10
yeah,
years, so much more is known. That is
yes,
one point. Plus,
yes,
if you looked at in both your esophageal cancer, gallbladder cancer, many cancers, liver cancer, in different parts of the world, although it is called the same cancer, the risk factors and the where it occurs in that organ and the histological variety changes very much. So I think in that context, I would like to ask the two experts, both Prabhat, you and Sujay, you are there. So, although you did a randomized trial, maybe just you only explain what it would the result and why you thought of also doing the omics in this, because it was already known. So, why you thought of it and what was the surprising finding?
Should I start or you will
Yeah,
start?
please, Prabhat, you can.
Sir, this is not an Indian data. The TCGA is not an Indian data. First
Yeah.
reason that we thought we should have our own data, whether we are have our own mutation profile, which is different from the West. In many cancers, we know that is true, and that same came out to be true in our case scenario also. And we were surprised to not surprised. Other studies have also shown that BRCA up to the tune of 25% BRCA mutations are there, which we found in our study also. And we are not EBV related. Most of these stomach data is from the east, where it is in Japan it is more EBV, or east side it is more EBV related. Our cohort is definitely not EBV related. So there was a pressing need to find our own data. Where are we going?
Yeah, so the primary reason behind doing this study was to look at the role of docetaxel, because when FLOT study came in the neoadjuvant setting for stomach cancers, docetaxel did show a good response in those tumors. So our aim was, or our question was, whether docetaxel, because even we see that clinically in the clinics that patients do respond nicely to docetaxel rather than single doublet of cisplatin and 5-FU. So we tried to see if adding docetaxel helps, and this was the best time for us to do parallel translational studies to look into the omics of the patients, and that is how we collected samples and sent them for translational studies, and we found this surprising data. So although the study was did not show a positive result in the terms that taxi in addition to the doublet backbone did not improve the survival, in rather it increased side effects, but a novel result that we got was this BRCA alteration seen in this patient population.
I think that's a very important point, that you have to see that this is a very diverse set of cancers, not just the histology, where it happens, what are the risk factors. So there is a classification, depending some of the based on genomic signatures, you can find out what was the carcinogenic factor which caused that. So there's a tobacco signature, there are different kinds of signature. So you get the same cancer, but the offending agent or the carcinogen could be very different. So I think that's what it has shown. And MSI high, you found only less than 1%. So was that surprise to you that so few MSI high?
No, sir.
No.
1 to 2% is what we thought. Yes.
Less than 3%.
Okay, you okay. So I think that's very important. Wherever you can have Indian data, many times we don't have it, but when you have Indian data, you should take that, look at it more carefully, and then decide your treatment strategy. And can we go to the case? Actually, just be here, Dr. Aparna Dhar, who is there. So when you do your patients, I think at your hospital in Delhi, many patients, just be here, be there. So, Dr. Aparna, when you send your patients, or do you look at the TCGA classification or the spectrum of mutations that you get? Is it same or different, or what do you get?
Hi, good evening, everyone. So I think for us, it matches more with what the TMH data shows versus
Okay. Yeah.
TCGA. Back in
Yeah.
the day, yes, that's what we looked at, but we definitely, I
Yeah.
think we concur with what TMH has presented.
Yeah. So that's, and other point, because we did not go into so much of epidemiology in India. If you look at stomach cancer in Northeast, what you get in Aswal, what you will get in Chennai, what you will get in UP, the carcinogen which has caused that may be very different. So although we say in India, but there are so many other varieties. So there is a need for people to understand that you have to take into account the racial factors, the risk factors which are operating, and how the disease is presenting. That is very important. So I think that's the point. Now, if you can come to your case, I think let us talk one by one. So sorry, you go the pathways for, yeah. So Aparna, if you had got this case, intrahepatic cholangiocarcinoma, and you had found this BRCA in somatic, which we later confirmed because we looked at it because it was high VAF, so we looked at it. And how would you have dealt with this particular case?
So I would have gone back to the medical oncologist. I would have actually asked them how the patient was responding to the current chemotherapy, especially if there was platinum sensitivity. If yes, then maybe we would have considered in maintenance recommending a PARP inhibitor. Yes, it's not standard of care, but in the case of intrahepatic, there is some evolving data that shows that in the presence of a BRCA1 or a BRCA2 mutation, we can consider giving a PARP inhibitor. So maybe that's something that that would have been the recommendation for the molecular clinic. And obviously, we would have also done Sanger over here. So, yeah.
So it's not a standard of care. And
No.
again, go back to that slide which you showed, both Sujay and Prabhat, that the TMH trial in which you found that 16% of them had either BRCA1 or BRCA2. I mean, of course, that was somatic. A few would have been germline, but mostly they were somatic. So based on that, you would have thought of in future studies on where you find, if not PARP inhibitors, at least platinum-based therapy.
Yes, sir. Platinum is already a part of initial therapy. Folfox or Capox is standard of care, and adding
Okay, so
docetaxel did
platinum is
not
already
show
included in
benefit.
that. Yeah, yeah.
Yes. And
Platinum
so
is
now
already.
we have submitted to IC and
Uh,
applied to various funding agency
mm,
where something similar to Polo trial in pancreas, where we
uh,
are trying to see after initial some cycles of Folfox or Capox,
mm.
we will give PARP inhibitor or 5FU only in the other arm.
Okay.
Maintenance olaparib versus 5FU is the trial that we have planned and submitted to IR ethics committee.
So all of them had oxaloplatin, and then you are seeing whether you will add, in them. So it sort of makes sense of that.
Yeah.
Okay, so now the case that you had shown that we've already discussed, I just want to ask Aparna, because you all do you were mentioning, I think, in your lecture, that in hepatobiliary, in especially bile duct, you see a wide variety of mutations which are targetable. So any particular type of, no, not that you had shown that bile duct and the
Based
key
on the
driver
anatomical
mutation.
side, yeah, you
Yeah.
have a very nice one, Anshul, the
Right.
one where you've got the BTC. You
This
can show
one.
this one. Yeah, this
Yeah.
is it. This
Yeah.
is it. Yeah,
Yeah.
yeah. Yeah, so in our practice now, I think if a patient has pancreas
Yeah.
or a biliary tract cancer, which would be gallbladder, extra hepatic, cholangiocarcinoma, we would be recommending an NGS. If
Okay.
the patient is affording, we do a CGP. If
Mhm.
the patient is not affording, we at least do a good 50, 70 gene panel, a full gene panel, not a hotspot,
Yeah.
where we look for these drivers, FGFRs, and we make sure it's with RNA because FGFR fusions are what you're looking for. So we'd be looking for FGFR fusions, we'd be looking for IDH1 point mutations, we'd be looking for ERBB2, BRAF. So I think today's standard of care, we do this, especially if we are considering starting with immunotherapy in first line. If that is an option, because if you do by any chance have an oncogenic driver like your FGFR, you know it's going to be very shocked that the patient is not going to respond to IO, but expect it to respond. So that's why in our practice today, we have started it pretty early in our NGS, pretty early in the patient's treatment.
Other related question, many of these are very advanced or patients are poor GC, so you may not have a big chunk of biopsy tissue. So liquid biopsy, whatever cases you do, liquid biopsy, does it pick up faithfully the pattern or the yield of the mutation that you got on liquid biopsy for these cancers is same or different?
So these are predominantly metastatic when they get diagnosed. So yes,
Yeah.
if there is metastasis to the liver and all, then yes, I do think liquid would be a good option. But sometimes we have seen discordance sometimes, and especially when we're not able to send it across to those FDA approved labs. Sometimes with our
Okay.
domestic partners, we have seen a challenge with respect to reporting, especially of the fusions. That
Of
doesn't
the
mean that their
fusion.
quality is subpar. I do feel that keeping cost and everything in mind, sometimes we can see a slight discordance. So liquid is a favored platform. I do use liquid in our clinical practice, but I'd be a little bit cautious with liquid if it's not done from one of the FDA labs, just because the depth of coverage, the data, the bioinformatics pipeline, the algorithms that they have in place, we are still working to get there, you know? So tissue would be our choice. If not liquid, yeah, not an issue.
So both Prabhat, you and Sujay, your choice of biopsy or NGS, liquid biopsy or whatever biopsy you have, and how often you are able to do this?
Sir, most of the time, the biopsy in gallbladder or biliary tract, in fact, in cholangiocarcinoma is without any evidence of malignancy, we treat sometimes. Difficult
Yes.
to occur with a biopsy. But gallbladder, we do get a good biopsy, but still gets difficult to do an NGS.
Yeah.
The sample is inadequate.
That's
It is
why I
not a
raised this
superficial
point. The
organ.
sample is inadequate. So
Yes. So sometimes we have tried using liquid, our in-house liquid biopsies these days,
yeah, yeah,
but still not confident to
yeah.
comment about whether it is adequate. Uh, cannot comment whether that is adequate or not.
That is, Sujoy, in your practice in Kerala, do you are able to do get biopsy samples or for NGS or liquid biopsy?
I
Uh,
start with the tissue adequacy to look for
okay.
if NGS can be done on the tissue itself.
Yeah.
Liquid is only and only if, meaning after considering other factors like the patient affordability and everything.
Yeah.
Very rarely I order liquid biopsy in my practice itself, but only if the tissue is not adequate. That is when I send for liquid.
So that is the reason why I brought this, asked Anchal to put this case. Although we have so many targets, so many targetable, targeted therapies. But first you have to find the target. And some of these cancers, bile duct and all, it is very difficult to get a good chunk of tissue on which you can, tumor tissue on which you can do all these, analysis, including looking for the fusion. And in that setting, because liquid biopsy is not routinely done in all the centers for all the patients, that's why I asked Dr. Aparna, what is her take. So that is, I think that's it. So gallbladder cancer, the outlook has not really changed much, and the targeted therapies, we are, a little long way in your practice. If you see 100 patients, of course 90% are advanced or metastatic gallbladder cancer. In Kerala, you must be seeing very few gallbladder cancer, Sujay,
Yeah.
isn't it?
Yes, sir.
Very few.
Almost no gallbladder cancer, only occasionally cholangiocarcinomas.
Yeah, occasional cholangiocarcinoma. So, but you probably see more of liver cancer, hepatocellular.
Yes.
Yeah, because of the alcohol, higher intake of alcohol. So we'll come to that. Prabhat, you must see seeing a lot of gallbladder cancer which are referred from North India, otherwise also. So in what proportion of them you think that you will find a target, or you treat them with targeted therapy or immunotherapy? If 100, gallbladder cancer, advanced or metastatic gallbladder cancer.
Yes, sir. So presently we test only for HER2, and very rarely do we do NGS. For HER2, we are actively doing part 2 of the TAP study that she showed, where we are it is a randomized study of
Yeah,
Gemcis
so the
versus
TAP study,
Gemcis
if you
plus.
can just elaborate, because she did not have time to go through it. So for the benefit of listeners and medical oncology trainees and other people.
Yes, sir. HER2 amplification was found in roughly 15% in various studies. From 10% to 47% it has been reported. So we thought at least 15% would have HER2 amplification. So let's see what happens. So we did a phase 2 study of Gemcis trastuzumab. We already know Gemcis trastuzumab can be given from breast. So whether this will increase PFS, a single arm study, we thought of 6 months will change to 9 months. And that is what we found, that in single arm study, PFS was roughly 9 months.
Okay.
So it was a positive study. But being a single arm and not will not change practice. So we now are doing a randomized study, phase 3 of Gemcis versus Gemcis plus trastuzumab.
Okay. So at least in this group of patients, there is some hope that you would improve that. Now, if you come to, can you Anchal bring that slide on pancreatic ductal adenocarcinoma, the various genetic? I think it was after this or before this. PDAC, yeah. Key driver, not just the before.
This one.
Pancreatic. No, this you are showing the stepwise progression. Key driver mutation, KRAS. Okay. So, did you explain G12D versus others? Did you explain that in your presentation? I
Yes,
don't
sir,
remember.
I did.
Anchal?
I did talk about them.
So, just explain that again for benefit of others.
Yes, so depending on what exactly is the variant, different drugs can be given. For an example, G12D, which is more commonly found, we do not have a direct
So,
targeted
is
drug.
G12D more common in all cancers, or you're talking of
No,
this?
sir. So in particularly in pancreatic, it's more common. When we see for lung and some other organs, G12C is comparatively higher in those cases.
Yeah.
So where sotorasib or atragacib can be given.
Okay.
But in our situation, it is kind of reverse. G12C is lesser found mutation.
So, Aparna, in the patient that you do for pancreatic adenocarcinomas, do you see the same what is given again? Because this is not an Indian data. The mutations you find G12D more common, or?
Yes, even in our Indian patients, we do tend to see, and we do a lot of molecular profiling with pancreas.
Almost
Uh,
everyone must be having, isn't it?
exactly,
Hmm.
exactly.
Hmm.
Irrespective of their background, even CGHS, ECHS approvals we get for doing this
Okay.
upfront.
Acha, you get it.
We get the approvals for these patients. So for them, yes, KRAS G12D is possibly one of our most common ones, and then we tend to see G12V. And then
Okay.
we tend to see the rest. So I do think somewhere it is very similar. Now, in addition to this, is that we see a very unique genomic landscape.
Yeah.
We see KRAS. If it's KRAS driven, we'll see a TP53. We'll see something called an MTAP loss. We'll see CDKN2A, N2B.
Okay.
And there is a very nice study by Dr. Rizal Kuzrock, where
Hmm.
she's looked at pancreatic, specifically these PDACs. And
Okay.
in particular, she has spoken about this particular combination that we tend to see, this particular genomic landscape. And what they do is post first line progression,
Hmm.
they try and do molecularly match the tumor. So what they do is for the KRAS, they give a MEK inhibitor.
Okay.
For the TP53, they add bevacizumab.
Hmm.
For the CDKN2A, N2B, they give a CDK4/6 inhibitor.
Okay.
And for the MTAP loss, they treat with an antifolate agent. And
Hmm.
that's a drug concoction that
Mhm.
they've come up with for individuals with such a pancreatic profile, with these profiles. And in quite a few of our cases, I will be honest, we may not do it up front in the first line
Yeah.
or second line, but I do feel that when a patient progresses after second, third line, we have started incorporating based on that. The
Okay.
PFS is definitely shorter,
Uh,
but in some patients now we've learned our lesson that when the patient progresses on the first line, and if they have a similar genomic profile, we switch to it in the second line. And I will say that the responses are far better. If it fails, then we go on and we, go back to standard of care. So that's just something in our experience we have tried. And we obviously counsel the patient and tell them this is not standard of care. We're
mhm.
just molecularly matching it based on this 81 patients' data that we have from Dr. Kuzrock, and then we leave it to them to make a decision.
Prabhat, your take on this? Prabhat, you and Sujoy,
Uh,
what?
yes, sir.
And
We are
the
few
toughest cancer to
smaller.
treat, isn't it? One of the toughest cancer
Sir,
to treat.
that is why I was coming to exactly the point. This 90 more than 90% KRAS mutation is the West again the Western data,
Mm.
where some form of smoking or tobacco is more common.
Mm.
Here it is in fact less common. Maybe they die. These tobacco chewers die with head and neck cancer here. So we have sent here our ESMO Asia. One of our resident has sent our genomic data of. So I
Okay.
will not disclose, but it is not up to the tune of 90% in our
Okay.
scenarios.
Okay.
It is way less. KRAS
Ach-
mutation is less in our
o-
scenarios. I
Okay.
just jokingly said that why it is less, I don't know. But in our
Okay.
pancreas, KRAS mutation is less.
Okay. So I think this again brings out a point. I think pancreatic cancers, Sujoy, you see maybe more in Kerala with alcohol and other things.
Not much, sir.
Not much. Okay. So they develop. Okay. But I think here also the data, because the agents which cause the cancer may be different. So the frequency of the mutation and the type of mutation and which alterations are more common may differ. Unfortunately, we don't have many data. So, but I think these cancers where overall prognosis is very poor, and we are basically looking for new treatments. I think this becomes very important. Yeah, you want to saying something, Aparna? No. So now if you can just bring up I think the last one, hepatocellular carcinoma we will discuss, and the key driver mutations in hepatocellular carcinoma. This one was for pancreatic. You had so many cancers. Yeah, you had okay. So in this, so again, very few are operable. The kind of hepatocellular cancers, at least in BC, are very advanced. In Kerala, do you see some early stage hepatocellular cancers, Sujoy?
Occasionally, yes, sir, because many of these patients are already on follow-up with the medical gastroenterologist.
Acha, for the cirrhosis and all. Yeah,
Yeah,
yeah, yeah. Okay. So they are picked up early.
yes.
Okay. And liver transplants, how often do you get, or they are suitable for liver transplants? Few?
Not much. Many of them
Not much.
are elderly, they're not that suitable for
So,
liver.
as a medical oncologist, what is your general sort of approach towards treating hepatocellular carcinoma? Because essentially, it's systemic therapy, otherwise. So,
Yeah.
what is your approach?
So wherever feasible, I start with immunotherapy.
Okay,
Otherwise, it's mostly lenvatinib, the oral
okay,
TKIs.
okay, okay. Feasible, you means patients can afford, and
Yeah.
that is what we, that's a terminology we use. Feasibility means patient can,
That's
can afford. That is because it's little impolite to write that you can't afford. People feel bad, so we say it is not feasible. For those who are not, don't know the terminology we use sometimes. The feasible means patient cannot afford, family cannot afford these expensive treatments. Uh, in your practice in Delhi, I think in your practice in Max Hospital, Aparna, most patients would be able to afford. Okay, so how are they approached? Based on the molecular targets that are available, or just IO? What happens in your center, Aparna?
Oh, not all our patients can afford. I may be in a fancy hospital, but
Uh,
no, we do have those that can't afford.
uh,
Yeah, so usually we do proceed with IO in those cases where we can't do NGS. In the patients
so
that
do you
can
get
afford
CGHS approval for that?
for IO,
IO.
yeah, our patients get it. Our
Acha,
patients get
okay.
it. From what I've heard from our medoncs, they get
Uh,
it. We may
uh,
not get approval for NGS at that point, to be very
okay.
honest. I have written letters couple of times and it's been
Uh,
rejected.
uh,
But in the case of patients who can afford, I think before they start IO, they
uh,
would like to get an understanding if there are any resistance mechanisms in place.
uh,
So
okay.
it varies. I think with HCC, we're still not there very strongly going forward and saying, look, this is very robust data. Do NGS upfront. So I think the standard of care is let's just start IO and then we'll figure it out as we go forward.
Okay. So you start with IO and then buy time to, yeah. Okay. Prabhat, you have anything to say for hepatocellular cancers, the treatment? I think you had a treatment slide, based on what is standard of care and what is no.
Yes,
Yeah. Okay.
yes, sir. Slightly old slide, but yes, that
Yeah, yeah. This
still
is
stands. So
yeah,
roughly work on systemic therapy only.
yeah,
And yes, hardly has any roles in this that
yeah,
I'm not aware of.
yeah. So I think we covered a lot of ground, and we there's so much to be done. So little is known, and especially in Indian context, I think for several cancers we brought this out that you need data. The data from Indian patients may be very different from the two of the studies in TMH and many other centers. So I think all the Indian data needs to be collected. Cases that are presented in tumor board, they need to be collected, and systematic studies need to be done so that we know what will really work for or not. So we are understanding the pathways. We are developing drugs for different pathways, and it is not just a pathway. What is the specific alteration in that pathway? The treatment may work or may not work, or it may cause resistance. So if any one of you have any concluding comment, Aparna, Prabhat, you or Sujoy. And I should thank all of them. Really helped Anchal make a good presentation, gave suggestion on what to include, what to reduce, and that then I sat with her. So you want to say
Absolutely, sir.
anything?
Even I'd like to thank all of them.
Yeah, yeah. Aparna,
I
you
think
have any?
I have 2 cents. Please, in these cancers, do germline testing. I know
Yeah,
we tend to do it more with pancreatic, but I can't tell you how many times, even where there's no family history, in our biliary tracts and our HCCs, we are picking up BRCA, we are picking up Lynch.
yeah,
So please do one germline testing. And where cost is not an issue, these are
yeah,
really heterogeneous diseases.
yeah.
Do consider CGP testing. If not CGP, at least do a basic good full gene 70 gene panel. Do
Thank
some element of basic understanding of the tumor biology.
Thank you. And I think on that note, I'll say GIST we did not discuss during this thing. In GIST, the genes which predispose to GIST are very different. So you have to see the panel that you will do includes the genes for the GIST. Okay. So both neuroendocrine tumors and GIST, you have to see what panels you have in the gene, because they may not be run of the mill, genes. So that you should be aware of. And if Prabhat, you or Sujoy, you have to say anything. Now you can talk about, you can address the medical oncology trainees. So anything you have to say about upper GI, stomach, and hepatopancreaticobiliary cancers, how they should approach towards learning the molecular pathways and exploiting them. You can just.
While going through the presentation, I was feeling the same with my down cutting this presentation. What we learn before just before the exam, molecular pathways chapter, they need not look after it if they later to this presentation. Excellent presentation by Apple.
Yeah.
We used to dreaded to start reading those chapters before the exam.
Thank you. Thank you. So, Sujoy, you can say the last word and then we'll close the meeting.
So my only message is in all these tumors, broadly we will look at two things. One of them is the tumor agnostic pathways that are the MSI, MTRK fusions, and RET fusions, which are in single digits but less than 2 to 3%.
Yeah.
And HER2 amplification is quite important for these upper GI cancers, especially the stomach, G-junction adenocarcinomas, and even biliary tract cancers for in Indian setting, mainly the GBCs, gallbladder cancers, because around 15% of the patients have this HER2 amplifications. And here HER2 directed therapy are approved and used in the first line setting.
Okay. So HER2 and tumor agnostics, these are the two things. For tumor agnostics, you need a CGP. That becomes the challenge. HER2 is very simple. That is the challenge. Anyway, we'll learn. So thank you very much. We'll continue with the seminars. And on Monday, we are doing sarcomas and melanomas. Okay. And you will see Dr. Prabhat will again be there in sarcomas and melanomas. And I'll send the PPT tonight. I'll ask the trainee to send tonight. Thank you very much. Thank you.
Thank you, everyone. Thank you. Good night.